To all who are new here, welcome. We've moved our regularly scheduled in-person journal clubs to an online platform. Fortunately, our fearless head of the journal club and liaison with the BOC, Brittany, has been working diligently to ensure that we are able to provide these educational opportunities successfully. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. Our next webinar is on Thursday about low back pain in athletes. For all athletic trainers who are intending to get live CEUs from the BOC, immediately after the webinar, complete the quiz, which will become available once the webinar has finished. In order to access the quiz, you must remain in the webinar until it closes. 1 hour after the webinar concludes, you will be emailed a link to the evaluation and assessment. We are aware that during our last webinar, GoToWebinar did have a glitch, but that has been corrected and everyone should have received their evaluation and assessment. You will have 24 hours to complete the assessment. Once you've completed the quiz and the assessment, you will receive an email with a link to download your statement of credit within the next 2 weeks. If you have questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. I am very proud to present our speaker today. Dr. Fran O'Connor is a nationally recognized expert in heat-related illness and exertional injuries. He serves as the current medical director of the Consortium for Health and Military Performance. He is a former president of the AMSSM, whose name is listed on nearly every sports medicine textbook in my library. And he'll be speaking from Bethesda, Maryland about the prevention of exertional illness. So I'm going to change the presenter over to him and we will begin.
Okay. So my screen is up right now, Michelle?
Yes, it is.
Okay, great. Well, I'm very happy to be here tonight talking about exertional illness, in particular my area of interest, which is preventing exertional illness. In particular, we're going to be talking about some of the lessons learned from the military. All the information that I'm going to talk about tonight, these are my own opinions. They should not be construed as opinions from the Department of Defense. Make sure this one panel is out. Let's see. Okay. All right. So, oh, here we go. All right. So what we're going to do is we're going to be talking about 5 cases, and then on these 5 cases, we'll move forward and talk about these different problems that I know you confront as certified athletic trainers. This first case, I'm sure many of you are familiar with. Wes Leonard, basketball player. This was back in 2011. He was a star basketball player, star athlete for his school. He made the shot, a lot of excitement, lined up to shake hands, and he's going over to shake hands. He suddenly started walking and then collapsed in line, shaking hands. Korey Stringer, many of you are familiar with. This occurred in 2001. This is actually an interesting picture that was in the USA Today. This is not the day that Korey Stringer collapsed, but actually the day before he collapsed. Practicing in full gear, hottest day of the year in the Midwest, vomited several times in practice, and then he was led into an air-conditioned shelter where he was accompanied by an athletic trainer. He complained of dizziness, became weak, and began breathing heavily. Dale Lloyd changed everything in the NCAA and the way we screen right now for sickle cell trait. Lloyd and his teammates were running consecutive 100-yard sprints, traditionally done at the end of football practice, as many of us have observed. Early on, he started struggling, breathing heavily, complaining of marked tightness in his legs. As the workout progressed, he had trouble standing. Finally, he couldn't hold up his head and he collapsed, conscious collapse. Michael Paros, this is a warfighter, first day of Ranger School down at Fort Benning, new graduate from the United States Military Academy at West Point. Falls ill during his first day of training. He had completed a long day of training. Final session was hand-to-hand combat, went to dinner, became nauseous, sick, presented to the emergency room. And then the last case, Doug Brenner, football player. This was fairly recent, January 2017, made national news. Brenner said the coaches had trash cans lined up for players to throw up in before practice started, not a good sign. After the first day when people passed out, Brenner said oxygen tanks were brought out to the workout. I could not even move my arms. My arms were so swollen I couldn't even take my own shirt off, couldn't even reach a fork to my face. I could not even eat. So with these 5 cases as background, and we're going to reflect on them, we're going to talk about some of the principles of prevention, how we prevent these things from occurring, and ideally address prevention strategies, the different categories for 5 different conditions that you see here: sudden death, heat stroke, sickle cell trait-related collapse, hyponatremia, and exertional rhabdo. So let's first talk about prevention. There traditionally are 3 stages of prevention that you should be aware of. A primary is keep the disease process from becoming established. Like COVID-19 in the background right now, of course, everybody is searching for an immunization, and that's the goal. But an immunization is an example of a primary prevention strategy. Secondary strategy, you're going to interrupt or detect the disease before it becomes symptomatic. We're going to be talking about heat illness down the line here, but clearly if you're in mild heat exhaustion, some people believe you might be able to intervene and try to prevent that from progressing to exertional heat stroke. That might be an example of secondary prevention. Tertiary prevention is going to limit the consequence of symptomatic disease. This might be, say, a middle-aged man who rolls in the emergency room, he's having a heart attack, and the cardiologists take him to the cath lab where he gets a stent to try to preserve myocardium. That would be tertiary prevention, trying to prevent consequences and preserve myocardium. And then finally, there's this one. And I think that all physicians, athletic trainers need to be aware of this. This is quaternary prevention. And this is an action taken to identify a patient or a population at risk for over-medicalization. This is where you're trying to protect your patient from perhaps too much intervention or too much screening that might do harm. An example might be something like, again, a middle-aged man who goes in for screening for a PSA, prostate-specific antigen. Used to be we used to get those on everyone. And now we've learned that by doing too many PSAs, we may in fact do harm. The intent being good, but you can do harm with overscreening. And we'll talk more about this as we move through this lecture. But bear that in mind. You've got a responsibility to protect against too much. Do no harm. That's the mantra in medicine. So let's get back to Wes Leonard, who collapsed in line in basketball game. Unfortunately, he had a sudden cardiac arrest, and this was a dilated cardiomyopathy. Of course, these scenarios are going to be your worst nightmare as a certified athletic trainer or a team physician. It's why you're there watching these games. Fortunately, these are rather uncommon. You'd like to say rare, but they're not rare. The risk of death in young athletes, 1 in 50,000 to 100,000 per year. So you're talking about 20 to 30 per year in the United States that are real events that are going to face a community. Obviously going to be somewhat higher in older athletes. But it's important for us to know that sudden cardiac arrest is the leading cause of exertional death in young athletes. Now, some of the things that are rather consistent in the literature is all the way back to 1992, but this just continues to bear out. It tends to be the boys over the girls, 5 times higher than female athletes. That's not to say a female athlete can't have a sudden cardiac arrest from an underlying cardiac disorder, but it's the men that generally have the much greater risk. College athletes are more predominant than high school athletes. Now, obviously, our athlete in our case was a high school athlete, but many of these things mature in college, and obviously college may be more stress. Non-cardiac deaths are about 22% of these deaths, most commonly heat stroke, for reasons we do not understand. Football, basketball players, more predisposed when you control for the numbers, and African Americans also appear to be at greater risk for reasons we don't completely understand. Now, this is perhaps one of the largest studies ever done looking at sudden death. This was done by Barry Marin. And you can see up here almost 2,000 deaths, cardiac deaths. And you take a look at where these were, commotio cordis getting hit in the chest, rather small percent, blunt trauma. The great majority is going to be cardiovascular. It's going to be the heart that's going to be leading to this event. And when you look at these cardiac events, most of them are going to be exertional, although there are a few that are non-exertional. And when we take a look at the cohorts, some of the more common things are going to be hypertrophic cardiomyopathy, coronary anomalies, myocarditis. And of course, this can be a big fear with COVID-19 is myocarditis as kids return to play. And perhaps we can talk about that later in some of the recommendations. However, that is, paradigm has changed. So traditionally we're taught it's hypertrophic cardiomyopathy. This is a study from the military. taking a look at deaths under the age of 35. And if you take a look here in this cohort in the military, the most common cause of sudden death in this cohort under the age of 35 is sudden unexplained death, meaning we don't know. Number 3 is actually hypertrophic cardiomyopathy, and you see here early cardiovascular disease being number 2. So unexplained in the military. And then you take a look at this study that came out of the University of Washington, Dr. Kim Harmon. She took a look and had a couple of interesting findings looking at this NCAA cohort. Sadly, Division I male college basketball players, remember I talked about the death rate being 1 in 50,000? 1 in 5,000 athletes per year. That is a real number. And the most common findings at autopsy, once again, autopsy negative sudden unexplained death, meaning that we don't know why that athlete died. Then follows hypertrophic cardiomyopathy and other things we traditionally think about. All right, so let's get in. How do we prevent this? How do we prevent it? Well, with primary prevention, we have universal precautions. The NCAA puts out a lot of this material, a lot of the high school federations, and we certainly do in the military. Number 1 is universal precautions. Introducing exercise gradually. That's known as exercise acclimatization. Environmental acclimatization. We bring a kid from North Dakota down to Fort Jackson, South Carolina. Going to be a marked difference in temperature and humidity. We're going to take at least 2 weeks to acclimatize that athlete, that warrior. Adjusting the workload based on hydration. We'll talk more about this, based on wet bulb globe temperature and workload. So this is something we need to be prudent about. Huge intervention. We see it in the military. We see it across the country. I'm talking to you from Fairfax, Virginia tonight. Every high school in Fairfax, Virginia has certified athletic training, perhaps the most important intervention we can make. And we see from the NCAA, from Brian Hainline, a real call out for any exercise programs that are being started on athletes, the role of a certified strength and conditioning coach who's writing down that program so that we don't hurt people. Secondary prevention. This is now where we're looking for occult disease. This is the pre-participation examination, and certainly most of these are going to be organized by the certified athletic trainers. And this needs to be conscientious. There is consideration for secondary screening, electrocardiography, echocardiography, and we're going to talk about that here in just a minute. Now, how do you do it? And here you see an example of a cardiologist who's taking his time to actually sit and listen in a quiet room. This cannot be a busy gym where you cannot auscultate, because auscultate with a stethoscope is still standard of care. Now, many people think this is the way we do it in the military. This is not the way we do it in the military, okay? We bring people into their own room. But you should all be aware that the new standard across the nation, which was just put out in 2019, was the 5th edition of the pre-participation physical evaluation. This is endorsed by all the major organizations in sports medicine, and there are some new standards in there that we need to be aware of. Number 1, the 12-point history and physical has gone to a 14-point history and physical, and you can see over here, and I believe all of you are going to get this as a handout. It's important that we go through this personal history, chest pain, unexplained syncope, unexplained dyspnea. I used to be able to take that hill last year, now I can't. Elevated blood pressure, prior restriction. What's the family history? Anybody under the age of 50 with a prior sudden death or disability? And then, of course, a very careful and conscientious physical examination where I've looked at this child, I've listened to the heart, I've looked for the stigmata of Marfan's, which you see here on this picture, and I've done a careful assessment of the blood pressure. Now, the NCAA has also published guidance. This was 2016. Here you see Dr. Brian Hainline, and it's important. This endorses the American Heart Association. It endorses PPE number 5. It's got to be a conscientious exam. But one of the important things that Dr. Hainline called out is that EKGs and echoes, they are not mandated. Okay, they're not mandated. Now let's talk about what this means. Let's talk about EKGs in particular as we talk about the quaternary prevention. Now, this was a landmark paper in 2014 where the cardiology community came out looking at the role of the 12-lead EKG in young people. And the first thing they came out and said was that there's insufficient information to support the view that universal screening of EKGs is required, okay, to include competitive athletes. However, they did come out and say that individual, quality-controlled, local, community, or student-related initiatives are supported if they're conducted properly and with adequate resources. So they opened the window that something like EKG could be endorsed if you're going to do it right. Now, this was a major controversy in AMSSM on people who were wondering about the value added in EKG versus the potential harm. We had a panel get together with AMSSM to take a look at this. Dr. John Dresner, myself, led this panel. And I think one of the most important things and concepts that we came up with is right here, this second bullet. And that is that athletes display differential risk, that not everybody has the same risk. And because they don't have the same risk, you may apply a different strategy for different groups. And this was a rather novel thought. So here we take a look at one publication. This was in the British Journal of Sports Medicine. You see down here what the baseline risk is of a Minnesota high school athlete, okay? But when you start looking here, college athlete is somewhat higher, male college athlete even higher, military athlete higher than that, African-American college athlete. You look at this relative risk, greater, okay, than this baseline risk. We get into male college basketball athletes, all races. And then finally, way up top there, African-American college males who play basketball. And that risk is dramatically different than the risk down on the bottom, which is opening up the conversation that, you know, you may or may not endorse EKGs for everyone, but boy, you can't ignore that there's a relative risk difference in certain populations, and you may use a different strategy. Now, all that being said, this is tough stuff. This is important to remember about screening as a challenge. This was an interesting study published in the New England Journal of Medicine, the premier journal, you know, in the world, taking a look at an outcome study of cardiac screening over in England, where they took a look at adolescents age 16. You can see here they followed them for 10 years. All of them got a history, physical, an EKG, and an echo. So they got the $1 million workup, all of them. During the screening, they identified a relatively low number that were found to have cardiac disorders. But the thing that jumps out from this study is that in this cohort of all these athletes, 6 athletes with sudden cardiac death, and there were 8 who died. There were 8 who died, as you see here. 6 of them had normal cardiac screening results, normal EKGs, normal echoes. So it just reinforces for all of us that sudden cardiac death is relatively uncommon, and screening is a challenge. Screening is a challenge. Tertiary prevention. Okay, this is where we come in, that you observe it. It's having bystander CPR. Trainers, students, doctors are familiar with how to do CPR. You have early access to an AED, and you know how to use it, and it works. And that most importantly, and this is where you see people burned, is that you can execute an emergency action plan that's written and you know how to do it and execute it. That's not just sitting on the shelf. So this is just an algorithm we use at the Marine Corps Marathon, but it reflects an emergency action plan, and an emergency action plan that you are familiar with, that you're able to execute, and that you've practiced and you've rehearsed and that you've documented that you've practiced it. So I'm sure many of you have seen this tape here of Hank Gathers. I know you can't hear it, okay, but this is obviously a classic video. As we watch here, Hank Gathers is going to make his last dunk. He had a known cardiomyopathy at the time, was on a beta blocker, questions about whether or not he was regulating his own dose. But you're talking about the leading scorer and rebounder in the country. You're going to watch him here with a sudden cardiac arrest. He's going to have exertional syncope right in front of you. So here he goes. This is national TV, your worst nightmare. He is clearly down, okay, and actually having some clonic activity, but notice he sits bolt upright. That's an interesting sign to suggest that he had an arrhythmia and he came out of the arrhythmia, and now he's going to go right back down and he's going to go back into the throes of ventricular arrhythmia again. And now you start to see him to have some seizure activity, not uncommonly associated with hypoxia to the brain. And you're taking a look here at the sports medicine fellow, the trainer, the head coach. You see the tonic activity right there. And the sad case here is they're going to be bringing a defibrillator on the court, and the defibrillator is going to follow him out. Unfortunately, he was not shocked early in the course. But every basketball game I know I cover, I'm always thinking, where's that AED? What am I going to do? God forbid something like this happens. Okay, let's shift gears here to heat stroke. Okay, so Korey Stringer, obviously this was a tragic death, led to the founding of the Korey Stringer Institute up in the University of Connecticut. This was an exertional heat stroke. Now, heat stroke is a major issue for us in the military, something I'm very interested in not only preventing, but one of the most important jobs I have is trying to make a decision on return to duty for people who have exertional heat stroke. In the military in 2017, we had 464 exertional heat strokes. We had no deaths. Now, sadly, last year we had more heat strokes, and we actually had 2 deaths last year in 2019. But in the civilian community, heat stroke is also prevalent, and of course, football is the major source of heat stroke, and it's where we really worry about it. And you look at this, this was published out of the Korey Stringer Institute. Since 1995, 54 football fatalities associated with heat stroke, 42 of those in high school. Okay, and you take a look here, there's some calculations on the incidence rate and when these things occur, very predictable. It's August. It's 1/3 occurred more than 2 hours into a long practice session, relatively predictable. But the sad thing here is when you take a look at the exertional heat illness rate, it's 11 times higher than all other sports combined. So I argue here, and I know Doug Cassa does as well, that exertional heat stroke is arguably the most common cause of preventable non-traumatic exertional sudden death in American sports. Heat stroke's going to occur, but nobody should die. Now, this is an interesting study from the Israelis that took a look at exertional heat stroke and do a very comprehensive review of all of them that are fatal. And they found these 2 items here: physical effort unmatched to physical fitness. They just knew it. This kid was not prepared for that load. And I'm sure you as athletic trainers can identify as well that, boy, look at this, 300-pound 16-year-old. He's not going to do well in the August heat. Okay, and then secondly is the absence of proper medical triage, which might have been one of the issues with Korey Stringer. Now, not identifying early on that someone's in the throes of exertional heat stroke and doing something. A lot of risk factors I'm sure you're familiar with. I want to highlight just a few. Poor physical fitness. And in many ways, it's a national disgrace. We know coming out of high school, a lot of these kids are not as fit as they used to be. There's not a lot of gym, but poor physical fitness is a major risk factor for us coming into the military. Lack of acclimatization, not being prepared for the heat load, obviously. And if kids are getting crushed in August and they've not been acclimatized, obesity is a major risk factor. Prolonged exertion, illness, major issue. I examine a lot of kids who have had heat strokes in the military. Many of them, probably 75, 80%, had an occult illness, whether it was bronchitis, a dental infection, a cellulitis, but that tipped them over on that particular day. Drug use, ephedra, dietary supplements, huge issue for us as well. We'll talk more about it. And of course, clothing. This is what warriors look like. They obviously don't go out in shorts when they do what they need to do, and football players also are loaded for bear as well and are at risk. This is an interesting study published by Cheryl Bednow out of Fort Bragg, North Carolina, taking a look at recruits. And we know within the first 90 days of service, if you are obese or overweight, you're 3 times more likely that you're going to have a heat event. It's that simple. If you're overweight, okay, you're a risk factor. I think anybody could recognize that if this kid's running around in August, he's got a risk. Okay? We're going to have to keep our eye on this kid. Now, meds. Need to be cognizant of what meds your athletes are on, especially during the summer. Anticholinergic, antihistamine for kids who have seasonal allergies, tricyclics for kids with depression, stimulants, obviously for kids with ADHD, diuretics, hypertension, antipsychotics, ACE inhibitors and beta blockers for hypertension. But I'll tell you, the biggest thing that I see in the military worry about is supplements, even among our own students at our medical school. Now, what you see here on this locker or on this cabinet is what was pulled out of the locker of one athlete, one warrior who died of an exertional collapse. And we all know most athletes don't take one supplement. They use many supplements. So primary prevention, what do we need to do? Well, if you're a medic, you're a physician in the military, you're an athletic trainer, of course, we're watching the wet bulb temperature. Okay, and we're trying to leverage prudent acclimatization and regulate the activity level based on what the blood globe temperature is. We're going to pay attention. Military uses exacting hydration and exertion tables, which I'll show you on the next slide. And we're going to be leveraging pre and inter-event cooling, anything to keep these kids cool. So this is what we use in the United States military. This comes out of Natick, Massachusetts, Usarium. And here, we can identify the heat category, we identify the workload, and depending on the workload, we'll have a work rest cycle, and we'll have a recommended water intake to the cohort to try to do our best to minimize risk. And who's in charge of this? It's going to be the leader. So it's the leader, it's the coach who has to make sure that this is implemented to prevent and hopefully mitigate against heat illness. NATA obviously has a very powerful guideline. This was again put out by the Korey Stringer Institute. They put this out trying to move this across the country on trying to identify that peak period, which is August, when a lot of these kids are starting their 2-a-days. But there is a progression that facilitates heat acclimatization that we want to try to pay attention to. So this is perhaps the most powerful intervention to a coach to mitigate against heat stroke through heat acclimatization protocols. Now, we also try to leverage a lot of pre and inter-event cooling strategies. Here in the military, you see some of the things we do. We use hand devices. This is a device on the left here in a Humvee, to facilitate external cooling. We use microclimate cooling clothing that can circulate cold water, slush, strategically placed during field training can keep people cool. You obviously will have input on whether or not people should be out doing things. This is a sign from the Chicago Marathon back in, I believe this was 2006, where the race was started and had to be stopped that it got so hot they ran out of water and had several deaths, a lot of heat strokes. We've had the same scenario with the Army 10 miler, where we've had to stop. But Dr. Bill Roberts has actually put out data, and this is published, where you can identify a temperature for your particular environment where a mass casualty incident may result, where you can make a prediction to say, what, race director, maybe we shouldn't go today. Secondary prevention. Here's what we do in the military. Well, we leverage the buddy system. We've got people who look out after one another. How's Johnny doing? Johnny's not acting right. Maybe he needs help because he can't recognize that he needs help. If you're a trainer, you're a physician, you need to be paying attention to one team. Maybe it's the women's cross country team all of a sudden's got 2 or 3 heat injuries. Like, what is that coach doing as opposed to the other teams? Or one unit. Screening for poor food, fluid intake, and of course secondary prevention includes, once again, leveraging heat dumping through devices like this hand device. Now, in the military, we use this term called heat dumping. So we'll use cool showers. Out during training, here you see kids down at airborne school going through cool showers. Again, you see in a football player here a hand cooling device. And perhaps one of the most powerful tools we're leveraging in the military right now is called the arm immersion cooling system that you see right here, where you roll up your sleeves and you're lowering your arms and your major vessels for about 1 to 2 minutes into a trowel filled with cold water, to try to lower the temperature and facilitate some kind of cooling. But it's heat dumping with the idea to try to mitigate that progression. Now, we also use in the military ice sheets out and about. This can be a secondary strategy to prevent that conversion, but it can also be a tertiary strategy to treat. I know you can't hear this video, but before people go out, the training, they go out with ice sheets and they have it available so that they can leverage it. So here you see a soldier going down and the ice sheets are put in place by the associated medics before the patient is going to be, or the medics and the drill sergeant are going to call 911. Okay. Tertiary prevention. This is where you're ready for bear. This is where, just like with that exertional sudden death, you're going to anticipate a heat stroke, and what are you going to do to save a life? Okay. So these are the people who are going down. Now here you see in this one cartoon, again, the implementation of the ice burrito, military ice burrito with ice sheets. Okay, we want to be changing these every 3 to 5 minutes while we're waiting for 911 to come. And here you see the technique used in the military. This is at the Marine Corps Marathon, where we have a semi-permeable gurney. This is ice water below, and the water, we ladle the water up and over the individual. That's a form of ice water immersion. So bottom line up front is that, you know, when these things happen, these can be very scary. And if you don't act quickly when someone comes in, these can be fatal events. So you got to have a team that is ready to go. So at the Marine Corps Marathon, here you see at one medical tent, we have 2 immersion cooling systems that are ready to go with medics who are well-trained, been doing it all summer. And we have a very detailed algorithm or emergency action plan on exactly how we're going to cool, how it's going to be done, who's going to be at the airway, who's got the rectal thermistor, when we're going to take them out of the cooling, you know, and then move on and how we're going to make an assessment. So this is kind of what it looks like at, I'm just going to show you briefly, because many of these people are athletic trainers or medics who are working as a team to execute. So here you see a doctor, here are the medics, our immersion or the cooling system. Here comes the collapsed individual, and you've got a team ready to go. Now the military, obviously we've got a lot of people who are available to work, and it does take a big team, as you're going to see here. But everybody on this team has a job, whether it's recorder, helping to control people, and if you've dealt with exertional heat stroke, you know these patients can be quite violent moving forward. And again, as I know you can't hear the video, I'm just going to move on. But I can tell you at Quantico, just down the road from me, they will probably have 100 to 120 heat strokes a summer. And these young medics are going to be saving an awful lot of lives. All right, next scenario. Let's move on here. Dale Lloyd, football player. Dale Lloyd, and of course, his fatal death led to changing everything with exertional sickle cell trait testing in the NCAA with the Division 1, 2, and 3. He had a classic collapse, showing signs of distress, breathing heavily, suffering muscle tightness in his legs, and then eventually collapsing. But when he collapsed, he didn't collapse like Hank Gathers. Again, he had initially a conscious collapse. This is exercise collapse associated with sickle cell trait. So I think it's pretty clear right now in the medical literature, even though sickle cell trait is considered to be relatively benign, it is associated with a few medical complications to include hematuria, which is blood in the urine, hypowastenuria, meaning that you can't concentrate the urine. In fact, most people with sickle cell trait by the age of 30 have difficulty concentrating the urine, which means that may predispose to dehydration. Exertional rhabdo or muscle breakdown, and of course, exercise-related sudden death. This is just one picture of 9 deaths in American football of young athletes who all died of sickle cell trait-related complications. Now, sadly, in the United States military, we had perhaps, it's estimated 7 to 9 sickle cell trait-related deaths in 2019. And at Great Lakes, these 2 young ladies here on the right both died. Both were sickle cell trait positive. Both deaths still being studied, but certainly associated with sickle cell trait. Now, the literature is fairly dramatic. These are some things that you should be familiar with. Classic military study published in the New England Journal again back in 1987 for almost 500,000 recruits. And we definitely found that if you were recruited in the military and you were sickle cell trait positive, your relative risk of dying was 30 times greater than if you were a sickle cell trait African American negative. Now, Kim Harmon again published another study taking a look at civilians at NCAA cohort, and she found relatively comparable data that if you were sickle cell trait positive African American, you had 37 times the risk relative to those who were African Americans without sickle cell trait. She also found that if you're a sickle cell trait African American football player, you had an absolute risk of death of 108 or 805, which is again a real risk. Now, let's go back to Marin's picture here, where we took a look at all these cardiovascular deaths and what was killing athletes. And again, the great majority of deaths are cardiovascular, and that's where most of your strategy should be. And you have to go all the way over here to this other category right here, where you finally get down to things like sickle cell trait related deaths. So sickle cell trait related deaths are real, they are present, okay, but they are relatively uncommon when compared to a cardiovascular death. And that's important Okay, you need to cover all your bases, but you do need to understand the relative risks. Now, we also know in the military, and this is very important as we're generating our policy, if you're a warfighter with sickle cell trait warriors do extremely well. This is one study. They had deployed more frequently. They had deployed for greater lengths of time, remained in the service longer. No significant differences in this one study in crude mortality. So sickle cell trait is not a bar to military service, and many with sickle cell trait do extremely well. However, once again, we go back to some of the NCAA data and some of the military data. This is real, that the exertional sudden death rate is greater. Most of what we know about this is drawn from case reports. This is the last NCAA death year. This is Ted Agu out of Cal Berkeley. Most of the deaths, it's an unconditioned military recruit or deconditioned athlete in the preseason, perhaps being overly pushed by the cadre at that particular time. Most of these deaths are going to be associated with repeat, intense exercise bouts where the athlete has limited time to recover. Another thing that is interesting about these deaths is usually it's an unusual muscle weakness, pain, or cramping. And those collapses, unlike the gathers collapse, is a conscious collapse. So they're initially awake before they become obtunded and go into a cardiac arrest. Now, there's a lot of questions out there. You know, is it heat? Is it hydration? Or is it intensity? And these are things that literature is still trying to sort out at this point in time, and it's debatable. John Kark, who did that early research in the military, thought heat was the key variable. Dr. Philippe Cons, who's a researcher down in Guadalupe, really feels it's dehydration, and that's a key variable. And I think most of us are familiar with a lot of the work out of Oklahoma with Randy Eichner and Scott Anderson, both good friends and colleagues of mine that truly believe that it's leadership more than anything else, and it's being pushed that perhaps it's the greatest risk factor. Now, we have seen this in the military, and we're currently studying this right now because this is very interesting to me as a physician researcher. I know in the military that the risk of sudden death in a recruit is about 1 in 90,000. So 1 in 1,090 recruits, and you're talking about a 1 million man service, 1 in 90,000 recruits is going to have an exertional sudden death. So there's 1 in 90,000, but 1 in 3,000 with sickle cell trait is going to die. But the question to me is, if I line up all 3,000, not all 3,000 are going to die. In fact, 2,999 are going to be fine. Who's the 1 in 3,000? How do I pick that 1 in 3,000 out? So we believe that yes, leadership, yes, exertion, and all the other risk factors we talked about are critical, but I also believe that there's the potential that there may be other genetic mutations that travel with sickle cell trait, and these are things that we are studying right now. There are no concrete answers just yet, but the bottom line is, to me, Fran O'Connor, my opinion, that not all sickle cell trait athletes may necessarily be the same. So we certainly have to be prudent with regards to all the stressors that we've talked about, but recognize that, why is it that one may be at risk and everybody else is not? So primary prevention, well, screening. And we now know in the NCAA, in particular, Division 1, 2, and 3, we screen. Okay, it's a requirement. However, there is an opt-out for athletes, but screening is there. But bear in mind, there are a lot of people who don't think a lot about screening. In fact, the American Society of Hematology came out immediately after the NCAA and thought that this was not a great idea. They recommended universal precautions. They felt that by screening, that's the only thing we really screen for in terms of genetics, that you may cause harm with stigmatization of an athlete. So they worry about that risk. That being said, it is what we do right now in the NCAA, and we do it in the Air Force, we do it in the Navy, and we're going to be moving forward with screening in the Army. There is guidance in the NCAA handbook, I think most of us are familiar with, that if you are sickle cell trait positive, these athletes need to be counseled. They should be setting their own pace. And I've highlighted another thing here, be excused from performance activities such as serial sprints or timeout runs, especially if these are not normal sport activities. Other than that, all the recommendations are recommendations that apply to everybody. Okay, so that's important. But recognizing that sickle cell trait athletes certainly may be greater at risk in those scenarios we talked about. That's very important. Secondary prevention, and this is perhaps the most important point, and that is that you need to be able to identify, in particular as a certified athletic trainer, an athlete who's struggling early on so that they can be allowed to rest and not push past their physiologic limit, allow them to reacclimatize and come back. So it is a recognition of someone who's in trouble that is perhaps the most important intervention. That's going to be chased, of course, by an emergency action plan. Other things for secondary prevention, I think the literature is fairly clear, and this is from a lot of the work of Philippe Kahn's. I mentioned about the hypoosmolarity, inability to concentrate the urine. Being well hydrated is key. So there should be plenty of access to fluids. They should drink ad libitum. Well, this is very important intervention. In addition to that, paying attention to leadership and adequate recovery. You got to have a plan for tertiary prevention. What are you going to do in your training room or on the field if a sickle cell trait athlete goes down? This is where it gets a little sketchy. There are some guidelines out there. NATA has a guideline with AMSSM. Most people believe that oxygen should be provided, but the first and most important intervention is get them out of the activity, get the oxygen, make your assessment, early movement with the anticipation of perhaps a fulminant metabolic crisis and alerting that emergency room that they need to be on guard for hyperkalemia in an emergent situation. Oxygen. Now, I'm going to show you a quick video here, part of a video, and this is the video that I was talking about. Actually, I have him on video, overtape, and we're developing an educational military video for the United States military on that for our recruits. He needed fasciotomies throughout his legs, and to this day cannot walk or cannot exercise with those legs because of the complications. Okay, so I'm looking at the time here, so I'm going to flash forward, because you've got my slides on hyponatremia, and you've got my slides on rhabdo. So I'm going to wrap up with this, and then hopefully we can have a robust some questions here. This is my bottom line up front for exertional illness, and this is what I have learned from the military in studying exertional collapse, rhabdo, heat stroke, sickle cell trait. In the end, the critical variable is leadership. Okay, it's the coach, it's the cadre, it's the trainer. Okay, we do not want to blame the warrior. We do not want to blame the athlete. They are followers. They are participants as well, and they need to contribute. But leaders are critical here, to include physicians and athletic trainers. Okay, very important what we do. We've published on this recently. Current Sports Medicine Reports in 2020, taking a look at cohorts. The leadership followership model and the very important roles in leadership and followership. But I think this variable of leadership is absolutely critical moving forward, and something to pay attention to in terms of education for our coaches, our drill sergeants, as well as our physicians and our athletic trainers. And I think with that, I am going to stop. I will share just one quick thing here. Yeah, my claim to fame as a military provider forever was in 1996, my first marathon. I got beat by Oprah Winfrey. Yes, I did, by a minute. But then 3 years ago, I was brought to the medical tent to take care of this guy who at mile 22 was struggling, took care of him, and he wanted to get up and go. I said, you know, I don't think you should get up and go. We went on and on for about 15 minutes. I said, well, listen, before you go, I'm going to get a blood test on you just to make sure you're okay, because he was signing out against medical advice. And I noticed everyone was going up to take a picture with this guy. I said, well, why are they taking a picture with this guy? And they said, well, sir, that's Kyle Carpenter. So Kyle Carpenter, what's the big deal? Well, that's Kyle Carpenter, who won the Medal of Honor at the age of 20 when he decided in a flash he was going to jump on a grenade to protect his Marines. And I went back to the young man. I said, Kyle, I said, why didn't you tell me, you know, that you were Kyle Carpenter? And he said, sir, I need to finish this race. I need to finish the race. But these are the guys that we take care of in the military, and I'm very proud to work to try to mitigate exertional illness in this group. So thank you, and I look forward to the questions. So back to you, Michelle.
All right, thank you very much. And we already have a large set of questions here. I am going to go ahead and start us off with, How do you believe that screening is going to change with COVID-19? And do you think there's any additional considerations to look at when facilitating screening?
Yeah, that's a great question with COVID-19, and I know you're aware, as I am, Michelle, that there's been some literature recently out from Boston with Aaron Bagish and John Dresner coming out of the University of Washington with people who had symptomatic COVID and the risk for myocarditis, that many people are recommending EKGs and echoes and clearance for these athletes prior to resuming sport because of the risk of myocarditis. So I think the first concern is if someone was symptomatic at cardiac screen. So that's the recommendation. It's going to be interesting to see how that's processed. I know as well in the military, we're not only concerned about cardiac, but we're concerned about pulmonary. In fact, in many hospitals right now, people aren't doing pulmonary function tests because when you do a PFT or aerosolizing material, but PFTs, I think, are also going to come into play at this point for people who had pulmonary disease, and that's going to be something to watch out for, and how we might have an increased risk for reactive airway disease in our athletes. And I know I'm very concerned as someone with exertional illness about underlying infection, the increased risk for exertional heat stroke. So I can tell you at Fort Benning, Georgia, we have a team. We're going to be watching very carefully what happens with exertional heat. But as athletic trainers, I'd be on the lookout for all the guidance coming out on cardiac and pulmonary in particular.
All right. And so you mentioned that the military is going to resume screening for sickle cell trait. How would you, can you give us some additional information on how you're going to be resuming that screening?
Yeah, Michelle. So the bottom line is right now is that the Air Force, the Navy, and the Marine Corps, they screen. Okay, the only service that is not screened is the Army. The Army has traditionally just enforced universal precautions, and they've identified everybody as one big cohort and used universal precautions and approached everybody with collapse at with the same mantra. But with some of the recent deaths that occurred in the past year, in 2019, the military, the Army, is going to move forward with screening. This was all being worked out, Michelle, right before COVID-19 hit. So the plans that move down a little bit lower on how the rollout is going to occur. But I'm sure we're going to do things similar to the Navy and the Air Force. And what they do is they screen, they educate cadre. The recruits are identified with a dog tag. The medical team is aware of those people who have sickle cell trait, and they have sickle cell trait emergency action plans. So I think the Army is going to roll out something very comparable.
Okay. Now, do you have any recommendations on in terms of the heat index in Florida? Sometimes the heat index in Florida gets to have its own asterisk next to it in regards to the high humidity and temperatures, and looking at wet bulb globe temperatures, the humidity impact on that. Do you have any recommendations in terms of heat indexes for Florida?
Well, just like the Marin paper, or Bill Roberts, excuse me, the Bill Roberts paper on identifying the not start time for the marathon. It's all about the region that you're in. Obviously, Florida and Georgia, South Atlantic have completely different heat loads than what we might have up in New York State, Maine, North Dakota, South Dakota, et cetera. So in the military, what we're going to do is recognizing those temperatures is we're just going to really reinforce acclimatization strategies. And I think it's fairly recognized right now that acclimatization takes at least 10 to 14 days to acclimatize. So I think you're going to have to be very prudent about acclimatization. I think you're going to want to try to leverage any way you can those times of the day that are least heat restrictive. but not being a physician who practices directly in Florida, but recognizing those people who live in that temperature and they've got a better chance of acclimatization, I can't pull a number directly out, but I do recognize they have a different challenge, and I think they just need to have recognition of how long it takes to acclimatize. And because you're in Florida, Michelle, right?
Yeah.
Yeah. Do you have any particular comment on any guidelines there for Florida?
I would say at this point, guidelines wise, we try our best to adapt the guidelines that are available nationally. And we know that in the Florida area, we are dealing with similar things in terms of trying to get them first acclimatized to the thermal load, and then adding on things like equipment, which prevents the ability to evaporate that heat and impacts that thermal load that they're dealing with. So, for us, it is always a challenge, because we do have most of our practice days and most of our game days are going to be hitting those high markers, and we all know that we want people to be able to participate in sports, but safely.
Yeah, no, it's a challenge. It's a challenge, and it's a particular challenge. Like in Virginia with our Army 10 miler a couple of years ago, all of a sudden you get a very unusual heat load on a particular day with high humidity, and we were crushed on that particular day. So I think you need to be flexible and adapt and pay attention to circumstances. And as an athletic trainer, have a dialogue with the coaching staff to say, hey, let's take a look at what's going on here, and maybe we need to readjust. Got to be flexible.
Absolutely. Now, there's one about Lieutenant Paros' video. So assuming the audio had the people around providing encouragement to him, and we often do see this in sports as people are struggling to complete the athletic activity. Are there efforts going on to change that culture of leadership in military, just like we're trying to do also in sports?
Yeah, so first of all, that wasn't Lieutenant Paros, okay? That was someone else, okay, who collapsed on that video. So Lieutenant Paros was the next case, and that was the exercise-associated hyponatremia. We didn't get enough time to talk about hyponatremia, but my message to the athletic trainers, as it is to the medics, if someone's sitting in front of you and they're vomiting over and over again, don't give them more water, okay? You may run the risk, try to look back and assess. So getting back to the video, that was the sickle cell trait collapse. And that's a very telling video that the leadership is very excited to show people, that there's a fine line between encouragement and recognition that guy's done. And he's in the throes of a medical crisis. Now that's where knowledge of sickle cell trait comes into play, because recognizing that colleague has sickle cell trait and recognizing the scenario where those legs are no longer working, you can recognize a metabolic crisis. But I would gather here, Michelle, that if you were to see that, and that was someone who's sickle cell trait negative, you'd stop the activity. That something's not right with that individual. Correct?
Absolutely.
Yeah. So yes, we are doing our best to educate. And I can tell you, I am literally probably days away from putting out a video with the individual you saw over talking that collapse, and he's describing exactly what's happening. So we're trying to educate cadre, we're trying to educate leaders, we're trying to educate the individual and buddies, try to help one another so that we don't run into these kind of problems again. Guy's lucky he lived.
Absolutely, that's awesome. So now, there's a few more COVID questions here coming in terms of, we've got actually quite a few questions here. Recommendations regarding hydration. And because as we know, we often use water buoys, we often use shared water bottles. It's already quite challenging sometimes to get adequate hydration, the coolers, the towels. What might be your approach when you are dealing with equipment regarding individual hydration?
And you're talking in the era of COVID at this point?
In the era of COVID, yes. Yep, going on currently. As we start going back, how would you approach hydration?
Okay, well, there's really kind of two questions in there, and one of the things I didn't get to hit on with regards to exertional associated hyponatremia was hydration in general. And first of all, with hydration in general, I think the big push, there was a NATA document that came out as well, led by Korey Stringer Institute, that the best strategy for hydration to prevent complications like heat stroke and rhabdo and sickle cell trait collapse is going to be ad libitum. Okay, so we don't want to force water on people, but we want water available, and ad libitum means when you're thirsty, you drink. Okay, so that's number one. But the question now, and the million-dollar question, I know I'm on a number of task forces. One, where the school I take care of, Michelle, we're up here in the A10, you know, working on all this, trying to pay attention to guidance coming out from NCAA, the U.S. Olympic Committee. FINOF came out with guidance on what are going to be the proper sanitation and hygiene procedures to protect people moving forward. And I guess what I would say, Michelle, is stay tuned. This stuff is, I hate to use the word fluid, but it's fluid right now. And I find the guidance is morphing, it's changing, it's being developed in terms of what is going to be the standard of care forward to have adequate sanitation and protection to mitigate the risk of COVID-19. So I'm probably just like you, Michelle, I'm staying tuned.
Yeah, I know. I was involved with the UFC event over the weekend, and it was obviously there's one athlete there, so it's easier in terms from a hydration perspective. But between bouts, everything was getting cleaned and sanitized, and you know they were really trying to minimize the interaction with as many people as possible. And it's very fluid. Trying to sort out what's the best way to do things.
Well, we are training right now in the military, but we have a luxury that a lot of people don't have right now, although I know college football is looking at this, and that is that we are bringing people in, recruits, and they're quarantined for 2 weeks. They're quarantined for 2 weeks, and then once they're proven to be, and they're being tested up front, so they're asymptomatic, and they've got no problems after 2 weeks, then they go into training for 2 weeks using social distancing, and then it becomes a matter of case finding. But the cadre, the trainers, and the recruits, you know, they're all basically training, but they're quarantined at that particular time as to mitigate risk. But I can tell you, Michelle, this is all changing weekly as we move forward. But the military has no choice but to continue to train for national security. So I think it'll be a good cohort to watch.
Absolutely, absolutely. And I do appreciate your time. I know there are a lot of questions here. In terms of people who are looking for the slide sets, that will be available on our website after the webinar. For 1 hour after the webinar concludes, you will be emailed a link to the evaluation and assessment. You'll have 24 hours to complete the assessment. Once the statement of credit is available for download, it'll be uploaded to our website and an email will be sent out to attendees. Thank you so much for speaking today. Thank you for talking on this topic as well as COVID. I really appreciate your time.
You're welcome, Michelle.
And thank you to everyone for attending. Have a great night and everyone stay safe.
Okay, have a great evening.